Okay, good morning. Thank you so much for joining the Calvet Women Veterans July 2019 webinar. My name is Lindsay Sin, Deputy Secretary for Women Veterans Affairs here at Calvet. We today are talking about women veterans healthcare. I have two speakers for you who will present on information and findings about women veterans healthcare both within the VA and findings among the Women Veterans Task Force with the House Veterans Affairs Committee. Just a couple of housekeeping items. This webinar lasts about an hour from 10 a.m. to 11 p.m., or I'm sorry, 10 a.m. to 11 a.m. It is available on our website. It will be recorded, as are all of our webinars, and you can find that at calvet.ca.gov/women veterans. Just a few housekeeping items. This is a recorded webinar, and you are calling in by phone or joining us through GoToMeeting. So please remember to mute your mics either on your computer, on your phones, or on the GoToMeeting software so that we can be sure to hear our presenters loud and clear. We ask that you hold all of your questions until the end of the webinar, although you can use the chat function if you're joining us through GoToMeeting to submit a question, and we'll try to get to your question at the Q&A at the end of the call. So up on your screens, if you're joining us via computer, there should be the ability to see the webinar PowerPoint slides. If you can't see them, then feel free to listen to the information that our presenters give to us, and you can always go back on your computer later once the recording's up and watch the webinar through the recording. So now I'm going to go ahead and introduce our speakers. Today we have Dr. Anita Patil, primary care physician and the Women's Health Medical Director for the Northern California VA Healthcare System. We also have Andrea Goldstein, Senior Policy Advisor for the Women Veterans Task Force for the House Committee on Veterans Affairs, joining us. So I'm going to go ahead and turn this presentation over to Dr. Patil to start us off. Dr. Patil, welcome. Thank you so much for joining us.
Hi, Lindsay. Thank you so much for inviting me. Can you hear me all right?
Yes, we can hear you loud and clear. We're happy to have you.
All right, thank you. Thank you for having me. I'm going to go over some of the, main things, benefits for the women veteran at our VA, mostly what's going on nationally, and I'll kind of touch base with what's specific to our VA here in the Northern California healthcare system. So just give you an overview in the next 20-25 minutes that I have, all right? We'll start with this first slide. It's just talking about why women veterans have become such a huge, important issue in our healthcare system. Yeah, and when you look at it, it's been a growing trend. And starting, if you look at 1945, there were only like 2.3% of women that were part of our active duty. And today, women are nearly 15% of our active duty and almost 18% of our Guard and Reserve. That's a whopping increase in our number of women who are joining the military. Next slide, please. Number of women at the VA, patients each year, starting from year 2000, it has grown to over 200% in the last 17 years. It's no, there is no excuse for us to kind of look at this and see what we need to do for our women veterans. If you look at the age distribution, starting from year 2000 to now, you see that there's been a growing trend of the younger veterans that have joined our VA, specifically 25 to 35 years of age. This is the childbearing age that has been actively growing and have been joining the VA for care. And then we have the 55 to 65-year-olds who are actually growing in number. Race, you look at the distribution, women actually have been way more diverse from the age of 18 to 44. Almost 40% of women are non-white. So we have American Indian, we have African American, Hispanic, and Native Hawaiian or other Pacific Islander who have absolutely increased in our numbers. Some of the VA benefits that we have for our enrolled women veterans is comprehensive primary care. which includes acute care, chronic illness, and gender-specific care from a single provider. We have routine gynecological care, we have mental health, disease management, prevention and screening, emergency care, infertility care, maternity care, including newborn care up to 7 days. We have specialty care, hospice and palliative care, long-term care and services and supports. Veteran Health Administration services for women veterans, they're expanding their service and sites of care throughout the nation. There's been an increase in the number of primary care providers who are trained to care for women, and we call them our women's health primary care providers or designated women's health providers. So in the last 10 years, their numbers have grown to up to almost 3,500 across the country. And then we have gynecologists on site, some of the sites, 196 across the country. Specific to NorCal, we have about 4 gynecologists in our system, and they serve pretty much all the way from Oakland to Wairika in all the CBOCs. We have mammography on sites. There are 60 sites across the country, and more are actually coming. Specific to NorCal, we have a mammography on site in Martinez and then one in Sacramento. And you can actually walk into these sites to get your mammograms done. You should be able to get your mammograms the same day if you walk in. Telehealth services, telegynecology services, telemental health services, and tele-wellness services. There's a little thing about general guidelines on eligibility. You need 2 years of active duty service, deployment in Operation Enduring Freedom, Operation Iraqi Freedom, or Operation New Dawn, anybody afflicted with military sexual trauma, and there's a ton of many special eligibility criteria. Each veteran, because they're unique, I would contact your local VA facility or call the 1-800 number for help with your individual eligibility status if you don't know whether you're eligible or not. Delivery of comprehensive primary care. We have complete primary care from one designated women's health provider. What does that mean? It's like one provider giving you all the care that's needed under one roof and one-stop shop. A designated women's health provider at one side. In NorCal, we have all the CBOCs. We have about 10 CBOCs in NorCal, and I'll go over that sometime later in the slides. But we have managed to provide more than one designated women's health provider at each site for the women's health, for the women veterans. And what do? They care for acute and chronic illnesses. They do gender-specific primary care. What does that mean? Treating menopause, contraception, vaginitis, so simple things that are not specific to gynecological care. Preventive services, mental health services, coordination of care, and these are all measured with women's health primary care evaluation tools and evaluated by site visits. Reproductive health, we have contraception, we have preconception care, maternity care coordination, newborn care up to 7 days, infertility care, menopause management, and gynecological surgery, which is all available at our Northern California healthcare system. Next slide, please. We also have VA maternity and newborn care. It's a known fact that we've had maternity care as part of our benefits package since 1996. And not a lot of people are aware of this, so we're trying to spread that, and mainly because none of our facilities actually have OB at the VA, and we outsource it 100%, so a lot of women are not even aware that we actually provide the service. Newborn care, as discussed, the first 7 days, is actually provided, and this has been enacted since 2010. Use of VA maternity care has increased by almost 45% in the past 5 years, especially if you go back to those slides where there's been a lot more women, childbearing women who've been joining the VA, obviously receiving care for maternity. VA maternity care, again, like I said, is outsourced and provided through the community care. So most of the hospitals that are close by are the ones that are affiliated with the VA that we outsource them to. Effective maternity care coordination is a critical component of our maternity care for women veterans. And it's a whole package. The VA specifically provides preconception care. There is the safe prescribing tool that we have. We have the VA care with obstetrics care in the community that is managed by our maternity care coordinator who is on site. So she literally is with the veteran who to provide her all the coordination right from the get-go, from when she has a positive pregnancy test all the way to her delivery. She helps coordinate care with the community, with the VA, to help bring her back to our primary care provider once she's delivered for postpartum and later after postpartum. We're promoting a lot of complementary and integrative health services, so trying to help the veterans focus on self-management and health. Mind-body techniques, meditation, mindfulness apps are available for the veterans for free. There's yoga and Tai Chi at certain sites, massage at few sites, art and music experiences. So when it comes to NorCal, we have the yoga and massage available at the Sacramento Mather Center. The other sites are actually looking at bringing these things as a whole health, but we haven't yet gotten them. Prosthetic equipment for women. There's a lot of women-specific prosthetic items, which include but are not limited to breast pumps, nursing bras, wigs for hair loss, long-acting reversible contraception, IUD devices, Nexplanons, maternity support belt items, vaginal dilators, women's eyeglasses, and shoes. Just so they know, the eyeglasses, so the optometry visits are absolutely, they don't need a referral. They can call directly and make their appointments for optometry and get their glasses and eye exams. Continuum of mental health care. Women are increasingly using VA health and mental health services. In the last, 2017, 44% of women veterans who use VA access mental health services. And these are available basically as a walk-in basis most of the times. They offer a full continuum of mental health services for women veterans, general outpatient, which, like I mentioned, they can walk in for these services. Sometimes when they see our primary care providers, if they mention anything about mental health or if they want to see somebody, they usually will be seen the same day by our integrated service of mental health. There are evidence-based therapies that are available, inpatient and residential treatment options that are available, which are mixed gender and sometimes women only. Some of the mental health issues. Women veterans are more likely than male veterans to be diagnosed with a mental health condition by a VA provider. In fiscal year 2017, 40% of female VHA users had confirmed mental health diagnoses. 25% of male VHA users had confirmed mental health diagnoses in the year 2017. As compared to male veterans, women veterans have higher rates of depression and anxiety, lower rates of substance abuse, higher rates of mental health and medical comorbidities. Clinical complexity among women veterans with mental health concerns is an area of special focus. Military sexual trauma. Military sexual trauma is a term used by VA to refer to experiences of sexual assault or repeated threatening sexual harassment that occurred during a veteran's military service. Unfortunately, military sexual trauma is part of some women's military experience and can have a significant impact on their mental and physical health. And VA has implemented a universal screening program in which all veterans seen for healthcare are asked about their experience of MST. Data from this program reveal that when screened by a VA healthcare provider, about 1 in 4 women and 1 in 100 men report experiencing military sexual trauma. We have specialized services to help, so all VA healthcare facilities provide free treatment for any mental and physical health conditions related to a veteran's experience of military sexual trauma. We have outpatient, inpatient, residential, and pharmaceutical treatment. Eligibility for this free care is expensive, and some veterans may be able to receive military sexual trauma-related care even if they're not able to receive other VA care. There is no length of service requirement, it is to be noted, no service connection required, no documentation of MST required. So basically, VA has removed all kinds of barriers for women to be able to access care related to military sexual trauma. And to access care, veterans can contact the facility military sexual trauma coordinator. All facilities, each one of our VISNs, each one of our facilities will have a military sexual coordinator, and they can learn about their services available or ask their existing VA healthcare provider for a referral. I've added the website here. They can access this also to get more information. Telehealth and connected health. We are expanding our services with telehealth. So there's a lot of talk going on about how we can expand and help our women veterans through telehealth services, especially women who are younger, who have children at home, who are unable to make it to our clinics. So telegynecology, telemental health, telewellness, telepharmacy are some of the things that are being looked at. They are being expanded. We've already started with some of them, but we have more hopes of starting that with, say, primary care and mental health too. So pharmacy, there's the My Healthy Vet app that you can go to for pharmacy refills, to look at your lab results, to secure a message to a VA provider who's most of the times they're able to answer your to your secure message within 48 hour business hours. There's a new app for appointments that's rolling out now. We're still working on it. There have been some glitches, but hopefully it will get better. There are many health apps on the VA App Store for PTSD, Coach, Move, and weight loss programs. There's also a Women Veterans Call Center that I highly encourage women to use, which is available during from Monday to Friday and also on Saturdays from 8 a.m. to 6:30 p.m. As of August 31st, 2018, the Women Veterans Call Center received almost about 80,000 calls and made more than 1 million calls, with 632,000 of these calls being successful, which means they spoke with the veteran or left a voice message. We've also implemented a chat feature back in 2016 to increase access for women veterans who responded to about almost 1,600 chats. Culture change in the VA. I'm actually heading our NorCal End Harassment campaign here, specific to our waiting areas, and we're trying to create a lot of awareness with posters, with training for staffing about harassment in the work area by veterans, by employees, and hoping that this will decrease. We have zero tolerance for harassment in the workplace and for female veterans. Air Force and Veteran Affairs Women's Initiative, Transition Assistance for Service Members. This was a new thing that was started. It's been piloted in some of the centers. We haven't done that yet in NorCal, but we are talking about it. Department of Defense and VA Health Executive Committee identified transition between Department of Defense and VA as the #1 barrier to care for female veterans. There's a myriad of challenges in relation to suicide, difficult to navigate VA during crisis, get those who need into mental health support quickly. Air Force and VA has partnered to pilot a program and address healthcare gaps for female veterans. There's a pilot one-day healthcare presentation with tour of VA facility, registration with the VA and the Veteran Benefits Association. Actually, it's a really good thing. So when they're transitioning care from the military over to the VA, there's a lot of things that the veterans are not even aware of, the benefits that they can get, and this is a great way of segueing the military active duty into the VA. They also track 2 years post-service to determine effects of healthcare presentation. VA healthcare is the largest healthcare system in the U.S. with over 8 million enrolled patients. More than 675,000 women veterans are right now enrolled at our VA. The increase in use of VA services by women is 9% per year, with 60% growth since 2009. I already touched base on the VA medical centers. 83% of our women veterans never access VA healthcare, and we're trying to have outreach events to help enroll these women and have them get the care that they truly deserve. Northern California healthcare system, Women's Health Program specifically, has 10 facilities. We have 2 main facilities, Martinez and Sacramento, and 8 CBOCs, which is a community-based outpatient clinic. We have over 25 women's health primary care providers across all facilities, and this has doubled in the last 2 years. So we're hoping each facility has a women's health primary care provider who can serve the specific needs of our women veterans. We were about 6,000 women in 2007. Now we're about 10,000 and growing, and we're hoping to capture a lot of our women from Oakland all the way to Wairika who can enroll. We still have a lot of women who are out there but not enrolled. Specific to our Northern California healthcare system, we also implemented a policy for emergency contraception that women need to know of, which means what they can do is they don't need to see a primary care provider. If they're enrolled, they can go directly to our pharmacy, ask for emergency contraception. Usually pharmacists will determine if they're eligible and hand them the emergency contraception the same day. They do not have to go to urgent care or see their primary care or wait for the primary care's approval to get the emergency contraception, and that's a big thing. We also have something called the Mamava, which is a lactation pod, and we're trying to roll that out in most of our clinics to have a dedicated room or a dedicated pod for women to breastfeed in a safe and quiet environment. And this is for our women veterans, for breastfeeding employees, for breastfeeding spouses who are accompanying the veterans to our clinic. The first Mamava pod has been already installed at the Oakland community-based outpatient clinic. Just so you all know, we have like 3 different types of models of women's health clinics. One is called Model 1, 2, and 3. The Model 3 is like the highest level. It's the state-of-the-art, has their own floor, it has its own waiting area. Mather, Sacramento, and McLennan are the only 2 sites at present which has a Model 3 clinic, which means you go up, it's all exclusive to women. Model 2 is where they have a separate floor, a waiting area that's, kind of separate, but they have a separate room, exam room, and an attached bathroom to it. And that is available in most of our community clinics. East Bay Women's Health specific, we have Martinez, which has about 800 patients with 4 women's health primary care providers. We have Fairfield with about 800 patients now with 3 women's health primary care providers. Oakland has over 500 patients with 2 women's health primary care providers. Mare Island has 200 patients with about two women's health primary care providers. It's always a good idea when you go get enrolled to ask specifically to be, assigned to a women's health primary care provider. Sometimes they'll designate a women's health provider. There is evidence that a women's health provider gives higher satisfaction. There's better quality of care provided. There's cost savings for reduced gynecological visits, especially for pap smears, because the women's health primary care provider is trained to do the pap smears and all the preventive care. And there's a sense of safety and comfort in these settings. That's all for me from now. Thank you so much.
Dr. Patil, thank you so much. This is a great deal of information. Every time I hear from the VA Northern California healthcare system, I learn something new about all of the services that are being provided to women veterans and how the usage of VHA facilities are expanding for women and how the services have expanded significantly in the last few years. I know I've got some questions for you at the end of our presentation. and I'm sure other people do as well. So we'll hold those till the end and now introduce our next speaker. Now I'd like to welcome Andrea Goldstein to present. She is the Senior Policy Advisor to the Women Veterans Task Force for the Committee on Veterans Affairs, the House Committee on Veterans Affairs. So Andrea, welcome. Thank you so much for joining us today.
Thanks for having me, and looking forward to sharing the work of the task force with you all. So thank you for, shall I just go ahead?
Yeah, just say next slide when you want me to answer.
Okay, so next slide. So the objective of the Women Veterans Task Force is to increase the visibility of women veterans in promoting inclusivity and equitable access to comprehensive health care benefits, education, economic opportunity, and other federal resources, particularly at the VA. So we are identifying gaps and opportunities, as well as identifying best practices to see how we can be supportive through outreach and legislation. Next slide. So the composition of the task force is chaired by Congresswoman Julia Brownlee from Ventura County in California. Senator Tammy Duckworth is leading companion efforts in the Senate. And it is a bipartisan task force. So we have 72 participating members here in the House, and any member of Congress may participate. So we have quite a few members from California. All of the members from California who are on the Committee on Veterans Affairs are participating, as well as several other members who are who are not on the Veterans Affairs Committee but are supportive of our efforts. Next slide, please. So our function, we are publicizing and advocating on behalf of women veterans through 3 primary lines of effort: outreach, fact-finding, and legislation. So there's a lot that we can do through this work. Introducing and co-sponsoring a lot of legislation. Our members have introduced over a dozen bills thus far, circulating sign-on letters to, say, the Secretary of Veterans Affairs. So we've sent letters to the Secretary pertaining to sexual harassment of both employees and veterans at VA facilities, as well as environment of care standards and some other issues that we've heard about pretty consistently from both VSOs and veterans, holding roundtables. So we've been holding about 1 roundtable every month here in DC, and hopefully at some point we will do one in the field. So we've talked about, we've done, the last roundtable we did was with women who are serving in elected leadership in veteran service organizations, and thinking about about experiences in the veteran space for women veterans and how that translates into policy, making it up to this level. And then, of course, hearings pertaining to women veterans. We've had 2. We had one in the Subcommittee on Health in May, and then we had one in the Subcommittee on Economic Opportunity last week, and that one ended up focusing very heavily on homelessness and higher education. Next slide, please. So we have 4 key policy priorities: culture, healthcare, economic opportunity, and benefits access. I think we all know that that cultural transformation is absolutely necessary, and we believe that the first step of that is, finding ways for women veterans to be visible. And we think the #1 way to do that is to prioritize women veterans and understand that women veterans are the fastest growing population, when oftentimes in the past women have been treated as an afterthought. So we are prioritizing women veterans and talking about some of the cultural challenges on a consistent basis, so that we can get to the root of the cultural challenges that might be hindering the best delivery of healthcare, economic opportunity, and benefits access. Next slide. So our events, as I said, 2 of our 4 subcommittees and the House Committee on Veterans Affairs have held hearings specific to supporting women veterans. There's another one planned in another subcommittee later this year. We'll also be talking at length, and we'll be having hearings specifically pertaining to the legislation that has been introduced. And our members have also been holding events in their districts. So we've had, some of our members have had roundtables, they've had town halls. We've heard back from our members that because of their participation in the task force, that they've also had a lot more women veterans turning up to their veterans events and engaging on those issues. So I would also encourage all of you to invite your members of Congress to, if you want to host them for a roundtable, to meet with women veterans or to meet with advocacy groups. Strongly encourage you to do that, because if they're a member of the task force, that is a high priority for them. So I strongly encourage you to reach out to them for those invitations. We're also addressing doing mainstreaming and addressing women veterans in all of our work. So we had briefings on suicide prevention. We had a hearing on suicide prevention. We had a briefing yesterday on homelessness, and the discussion of women veterans were discussed at length, where I think oftentimes if we don't specifically raise that issue, it isn't addressed, and it is a big priority for the chairman, the chairwoman, and the entire committee. So women veterans are discussed and addressed in all of the work that we do. And we do have our monthly roundtables. They are almost all open to the public. So if you happen to find yourself in DC when we're having a roundtable, you're welcome to join us. They're not televised, unfortunately, unlike the hearings. But like I said, we had a hearing last week on economic well-being of women veterans. So you can find that on the committee's YouTube site. So for the next slide, I'm going to breeze through these pretty quickly because we have a lot of pieces of legislation. But if you want to take a look at the slides later, you can see the bill numbers and take a look. But we are addressing what have been identified as several gaps. The Senate has already introduced the Deborah Sampson Act, and if you're familiar with that, you'll see that many of the bills that we've introduced here in the House do correspond to those. So our bills many of the healthcare bills are about ensuring that there's equity in access to gender-specific care and solid environment of care standards are met, and that and then also conducting studies to identify any gaps that need to be addressed. So so on here you have the first slide. We have Equal Access to Quality Care Act, which is my boss's bill to ensure that gender-specific services are continuously available within VA. We're also addressing legal services for women veterans. We've heard quite a bit about a need for that. On the next slide, we discussed in the VA briefing earlier, there was the discussion about the Women Veterans Call Center. Oftentimes, if there is a program that's really great that isn't necessarily in statute, we will introduce legislation to ensure that that program remains permanent. So this bill would do that. We have a member who wants to address the motto, and we want to reauthorize the study of the barriers for care. So going from, I'm going to just go through here, skipping over this next slide because this is part of the Deborah Sampson Act. I wanted to skip to the slide that starts with HR 2942. So this is actually the first bill that's going to go to the floor. We talked about the Women's Health pilot program with the Air Force. Both the majority and minority staff had an opportunity to sit in on that course. It's really fantastic, and I definitely, as I'm a Navy veteran myself, I wish I'd had that introduction. So we're authorizing the extension of that program through the end of next year. So we're really hopeful we've already heard really great preliminary results, and I think it's a really great model. We're also working to address housing and homelessness. the making permanent the retreats program, extension of the coverage of newborns from 7 to 14 days, identifying availability of prosthetics for women veterans to ensure that, for example, a woman veteran can have like a prosthetic that fits a high heel, and ensuring that there's coverage for newborns in emergency situations. So that should cover all the legislation. I know I breezed over it, but what I really wanted to take the opportunity to do is answer any questions as well. So I think we're at the questions portion for all of us.
Thank you so much, Andrea. Yes, we had a lot of legislation on here that you provided. I know there's even more that's not healthcare related, so yes, it's an incredible amount of work that you're doing with the task force and Congresswoman Brownlee and all of the representatives that are involved in this. It's much appreciated. So we can certainly open this up for questions now. I'm sure people will have questions specific for you as well as to Dr. Patil regarding care at the VA. So if anyone has a question, please go ahead and feel free to ask that now. If you ask it via the chat window, then we will get to that as well. If you're using GoToMeeting, I encourage the chat window just so that we can keep everything else, the phone line as open as possible. So ask away. All right.
Hi.
Well, go ahead. Hello.
Hi, my name is Isel. I'm an Army veteran and a healthcare advocate. This has been some really interesting information. I've been happy to hear about all of these programs. The thing that I'm wondering about is we're having this discussion on women's healthcare, and while obviously the VA cannot provide abortion services, this is a tremendous part of the full spectrum of services. So my question is, what happens when a veteran goes into a facility with a pregnancy that they can't carry forward?
Dr. Patil, do you have an answer to address that scenario? What typically happens?
Sure. I do. So this has been, we unfortunately do not provide any care with the abortions in the military as well as the VA. So when a woman comes into our clinic, say who does not want the pregnancy, we refer them to our maternity care coordinator. And what she does is she gets a good history on them, and depending on where she is in the community, she will refer them out to she will hand them the resources. She'll make sure she has all the resources and the clinics that are available around that will actually help her out.
Excellent. That's what I was hoping your answer would be, but I wasn't sure because myself and every other woman veteran I've ever known has not even dared to walk in the door to seek help. Because no one knows what's going to happen when we get inside because there's no information anywhere. And I wonder if it would be useful to let people know that they will be helped as opposed to shunned or treated badly. And that's the end of my question. So I'm going back to my mute button, and thank you very much.
Thank you, Isel. We appreciate it. Yeah, it's good to know that the maternity care coordinator can be at least a resource for an individual that needs to access services to terminate a pregnancy or abortion services. I've had women contact my office who needed similar services, and we pretty much did the same thing, provided some resources to local clinics that were able to meet their needs. That said, oftentimes with abortion, the cost can be an issue, so any way that women can be referred to services that are low cost or free at a community-based clinic, I would encourage them to seek that out, but certainly the VA can be a resource in this sense as well. So that, at least for information, that's nice. Okay, we have a question from Krishna on the GoToMeeting chat. she's asking, Krishna's asking, is there any research being done in reproductive health issues related to deployment and sexual assault?
I honestly am not aware of any research that is being done specifically in the VA.
Okay.
So I can find that out for you and respond to that to Lindsay later.
Thank you. Thank you for the follow-up.
Yeah.
So we will in our, I believe it's going to be our August webinar or our September webinar, because this is part one of a three-part series on women veterans healthcare. We'll be talking more about reproductive healthcare in those two webinars. We will be talking about some research that shows some negative outcomes of PTSD and perinatal care or perinatal or birth outcomes and postpartum outcomes or birth outcomes for a mother and a baby if they have PTSD. So some of what is going to be discussed relates to the issues of PTSD, which could be a result of military sexual trauma experiences. But we'll certainly try and get you more information to see what studies are out there and what research is being done. We will be connecting with a few of the more prominent VA researchers here in California who focus more on studies, population studies of women veterans, so we can get more information on that. Any additional questions for Dr. Patel or for Andrea? So I have a question for Dr. Patel. How do you feel the VA Mission Act and what is essentially expansion of community-based care as well as extension of some VA services, how do you see that impacting women veterans in your day-to-day operations as the lead women's health director?
You did not go there, Lindsay. So, the Mission Act has been put in place mainly to help people who are in the rural areas who are not able to access the VA. We here, in the NorCal system are pretty good. So there's all the way from Oakland to Wairika. There's some areas in Wairika, Redding, Chico, Yuba, where they're really, really far from their primary care providers. And if they are, according to the Mission Act, which is really good for them, is they're able to go to a provider that's closer to them. And there are guidelines as to, within 50 miles or within 100 miles for specialty, within 30 minutes and things like that that they can identify and then be referred through the Mission Act to a primary care provider that's closer to them or a specialty that's easier for them to access. And I think it's a really good thing as a supplemental health for our veterans. But we still are going to continue to provide most of their care at the VA, and we still are going to be able to provide them with easier access. We've always been better with the access than primary care, than private world, anyways, at the VA.
Okay, great. Yeah, the rollout is just a month old now, a little over a month old for the Mission Act to go into effect.
Yeah.
So I think the more information that women veterans and even primary care providers or community-based services and providers of community-based services, the more feedback they can give, the better, so that we can make sure the Mission Act's meeting its goals and meeting the needs of the veterans.
Oh, absolutely. And it's so new that we're still going through what is going to happen. For now, we're seeing that the veterans are choosing to stay with the VA because they are established, they like the providers, they want to continue care here, even if they're a little further away. And so, but a lot of times, again, if they're really, really far away, it's a really, really good option with the Mission Act.
Great. And so, Dr. Patel, one more question for you. What do you feel is the most important thing that callers need to know? So either women veterans on the call or some of our service providers about VA healthcare for women veterans and making sure that they are connecting women veterans with this care. What's a tip or the most important takeaway that you can give us for that?
Well, for most, if you're a veteran, if you're a female veteran, I highly encourage you to enroll and at least try the VA out. Go to their website, look for all the services that are specific to you that we provide or not. We have a lot of outreach programs. One of the big ones that's coming up is in October 19th at the Veterans Hall. And Lindsay, I'll send you the information so you can dispense that, which is in Vallejo. And these events basically bring all these, so the social workers in there. They'll bring our MSD coordinators, the maternity care coordinators, myself, along with all the other women, some of the women's health providers, so they can go around and ask all questions that they might have. There is, I would highly encourage veterans to go to the VBAs, the Benefits Administration, to figure out what their benefits are and make most use of it, because there's plenty available, and there's not a lot of awareness around it. So, and the VA website there's tons of information available on the VA website for our women. And feel free to call. There's someone called the Women's Veteran Program Manager at every facility, and they have a 1-800 number. So if there's any specific issues related to a specific veteran, she can call the 1-800 number, and our Women Veterans Program Manager can help her coordinate the care for her, specific to her. So definitely get the number of the Women Veterans Program Manager, because they're there as their patient advocate for them.
Thank you. That information is also available on our website. There are 8 VHA facilities throughout California. So if your VHA facility and your Women Veteran Program Manager is not putting on an event where we're bringing all of the VHA offices as well as the Veterans Benefit Administration offices together for some community event for women veterans, I highly encourage you to contact us or contact the Women Veteran Program Manager and ask how we can do that. San Diego, Loma Linda, NorCal VA are just some examples of this happening pretty regularly, where there are day-long retreats for women veterans to access all manner of care and services with the VA. They're really great outreach events, good opportunities for women to get together and to seek services. So if your program managers aren't doing that, then let us know, and we'll see if we can get something started. We have another question on the chat window. Erica's asking, in regards to OBGYN referral services, you said that those are contracted out. Is that provided to women who are only service-connected for those issues, or are women who are 50% service-connected for other issues eligible too? What is the
is the one that's contracted. We actually have gynecologists on board. And the OB service, you have to be a veteran. I don't think you have to be service connected to be able to avail that benefit. So you have to be a veteran, and there's the eligibility criteria for the veterans, and you qualify to avail those services.
So I would encourage you, Erica, to contact your eligibility office at your VHA facility. They can give you more information about what that criteria may be. It may not be connected to the contracted service, but more to your individual or someone's individual eligibility as a veteran, perhaps. I hope that answered your question. If not, feel free to ask again. Okay. I think we have time for more questions. So I have a question or two for Andrea. Does anybody else have another question to ask, either via the chat window or over the phone? Okay, so my question for Andrea, Andrea, how do you think it's best for callers, women veterans, veteran advocates, male veterans, all of us to continue to support the task force's efforts so that we can see some lasting policy change that you're introducing and putting forward?
Sure. So there are a couple of ways you can do that. Certainly, I think that some of the best things you can do it's twofold. First of all, if you are having an event that's related to women veterans, I strongly encourage you to reach out to your members of Congress. If there's an opportunity to invite your member to come speak, that's I recommend that because it'll bring them in and it'll give them the opportunity to hear directly from you. And failing that, they will likely send district staff, which is another great way for you to get your word directly to that member. You can, and ultimately, ultimately a lot of this does come up to me. But again, that we have 72 members, many of whom are in California. So definitely engage with them. If you are part of a local group, sending a letter to the members' offices or to my boss, to the chair of the task force, those make it to us, and those are actually very helpful for us to think about what policies need to what policy changes might need to take place. And you can you can also reach out to me directly, but ultimately what's really helpful is in reaching out to those member offices, particularly those members who are members of the task force. Again, all of the members of the House Veterans Affairs Committee who are from California are members of the task force, and let them know what your concerns are. My email, I think, is our emails are public. It's my first name dot last name at mail.house.gov. We're very interested in hearing about what challenges and opportunities exist. What's also been great about being on this call is hearing about best practices. We don't hear enough about best practices. So if there is a facility, if there is a program that is really helpful, we want to hear about that as well. And again, you can reach out to me directly and also engage with your elected members of Congress.
Thank you very much. Okay, and then what would you say, Andrea, just a follow-up question, and then we'll open it up again for everyone else to ask questions. What do you think is probably the most interesting thing you found in doing this work over the last 6 months?
I think the most interesting thing, it's not necessarily concrete, but that there are just a lot of cross-cutting issues that haven't been addressed because no one's really been digging into them. So I won't give specifics, but certain areas that are significantly impacting women veterans where policies just don't exist. And they probably should.
Okay. So we still have a ton more work to do.
Yes, there's a lot of work to do.
Yes. And you've let me know as well, I think it's important to share with the group that, this work is continuing, that right now this task force is going to continue at least through this Congress, and then may continue thereafter. So the good news is that we've got time to continue to do this work and make something real happen and affect real change, right?
Yes.
Yeah. Okay, more questions for Andrea or for Dr. Patel?
Hey, Lindsay, can you hear me?
Oh, I can. It looks like I just got a notification that GoToMeeting has stopped working, so we are still on the call, which is good, but the chat function may not be working. Can everybody hear me?
I can.
Okay. So we're going to go ahead. Thank you. So we're going to go ahead and.
Yes.
Okay. Thank you very much. Ask your questions if you have any more via the phone, if you can, since something seems to be going on with the software. Does anyone have any additional questions at this point?
I do. This is Christine Stanley down in LA. Hi, everybody. I just wanted to extend to the callers that if they're interested in the California Women's Leadership Council, to please get on the Calvet website and send us an email, and my phone number is there. And we're working a lot with the task force. So if you have any issues, we have a monthly call, and we can address them there and then send stuff forward as a council to the task force. So that's all I have.
Thank you, Christine. Great reminder. So please visit our website, calvet.ca.gov/women veterans, where you can find information about past webinars that we've recorded. You can also find information about the Women Veterans, the California Women Veterans Leadership Council that Christine just mentioned. That's another way for you to be involved in advocating for women veterans. Andrea Goldstein's email, andrea.goldstein@mail.house.gov. Is that correct?
Correct.
Okay. And this is one part of a three-part series. So we will be back with you for a webinar in August and then another one in September. The August webinar is scheduled for Monday, August 21st at 10 a.m. Tentatively, we are scheduling September 18th for the September webinar. That may change state-wise, but look for more information in our monthly email message that will come out at the beginning of August. We also encourage you to stay connected with us and join our Women Veterans roster if you've not done that already. You can shoot us an email at womenveterans@calvet.ca.gov, or you can go on our website to our URL and sign up electronically that way. That helps us keep in touch with you, and it allows you to stand up and be counted. Thank you again for joining us. Thank you both to Dr. Patil and to Ms. Goldstein. We really appreciate your time and this great information. Please contact us anytime if you have any questions. Thank you for your service, and we'll see you again in August. Goodbye, everybody.
Thank you. Bye.
Bye. Thank you so much.
Bye. Thank you.
Thank you. Have a great day. Number 2.